Good evening. Our lecture today about thrombotic diseases. فاطمة عبد الوهاب, Clinical and Chemical Pathology Australia. This is the Fergal Triad. Here, there is the main causes of vascular thrombosis, whether arterial or venous. First, there are three main causes: the vascular damage, either by inflammation in the veins, the thrombophlebitis, or outside the veins, as cellulitis, atherosclerosis, vascular narrowing, venipuncture, prolonged venipuncture, or physical trauma. There is a circulatory stasis. What's meant by stasis? Stasis means sluggish or slowing the circulation. Prolonged immobilization, bedridden, venous obstruction, as DVT, varicose veins, the AF or atrial fibrillation, one of the main causes of venous thrombosis. And then, hand in hand, is the hypercoagulability. And here is the different causes that causes hypercoagulability. This slide shows the normal balance between the coagulation and naturally occurring anticoagulant. There is a balance between the procoagulant activity and the anticoagulant activity of the body, and hence, when I am generating thrombin with the initiation of coagulation and then promotion of coagulation, every step has its limitation, naturally occurring anticoagulants, such as the protein C, protein S, and thrombin 3, naturally occurring heparins or heparan sulfate, and the naturally occurring anticoagulant. Here in thrombophilia, in the right, there is a diminish in the anticoagulant activity, such as protein C deficiency, protein C, protein S, factor V Leiden, or there is excessive thrombin formation by a different acquired thrombophilic conditions, or antithrombin 3 deficiency, and hence promoting thrombosis. This slide shows the main causes of inherited thrombophilia. So, increasing the procoagulant, decreasing the anticoagulant, or abnormal fibrinolytic, and others. There is example that factor V Leiden. The factor V Leiden, it became resistant to the active protein C effect, or prothrombin mutation, or hyperhomocysteine, or decreasing the anticoagulants such as antithrombin 3 deficiency, protein C, protein S deficiency in heparin cofactor 2 or tissue factor pathway inhibitor, or abnormal fibrinolysis such as decreased tissue plasminogen activator, increased plasminogen activator inhibitor 1, increased thrombin activated fibrinolytic inhibitor, or others such as PNH. This slide demonstrates when I should test my patient for thrombophilia. If the thrombosis occurred provoked, what's meant by provoked? Provoked that can be explained. A male, old age, with arteriosclerosis, with myocardial infarction, another site at the site of trauma, or a bedridden, prolongedly bedridden. When I'm having a general predisposing factor for thrombosis, I should not test my patient for thrombophilia. I should test if the thrombosis in unusual sign, or if the thrombosis occurred unprovoked, or if the thrombosis occurred with a very trivial provocation. Example given, DVT in a young children. Even he is a bedridden, we shouldn't find a DVT in a child. Or it occurred in an unusual sign as flank neck vein with enteric vascular occlusion, Budd-Chiari syndrome, or if it was unprovoked, and hence I should test my patient for thrombophilia. Here on the right, there is the syndromes associated with hypercoagulability, such as the antiphospholipid syndrome. I should test by the lupus anticoagulant, the RVV test, and phospholipid neutralization, the RVV confirm, and the anticoagulabin, by the way, in addition to history. If I am suspecting my patient have a naturally occurring anticoagulant deficiency, such as the antithrombin 3, protein S or protein C, I should measure them to exclude inherited or acquired deficiencies. I should test by a functional assay and confirm by antigen assay. If my patient have a thromboinflammatory condition, such as nowadays we had seen many patients with COVID pneumonia with unprovoked thrombosis or pulmonary embolism. If my patient having a factor V Leiden mutation. What meant by factor V Leiden mutation? Normally, the factor V is inhibited through active protein C, which is a naturally occurring antioxidant. The factor V Leiden resists the inactivation by the active protein C, and hence, I having an active protein C, I'm having a functional naturally occurring anticoagulant, but my patient will have a resistance to inactivation by the active protein C, and hence causing thrombophilia. Also prothrombin gene mutation. This diagram illustrates the diagnostic criteria of the antiphospholipid syndrome. When we stuck to the definition through unexplained or unprovoked thrombosis, history of pregnancy-related morbidities, and laboratory assay of the lupus anticoagulant, anticoagulabin, and the anti-beta-2 glycoprotein. Here is the detailed laboratory criteria to diagnose antiphospholipid syndrome by identifying the lupus anticoagulant. What's meant by lupus anticoagulant? That prolongation of the PTT by a phospholipid sensor dependent clotting assay. Evidence of the prolongation of this screening test is corrected by the excess of the phospholipid, which is a confirmatory test. A small hint on the thrombolytic therapy. I can't measure thrombosis and ignore in my lecture the thrombolytic therapy. The indication are the peripheral or a central vascular occlusion. Thrombolytic therapy usually act by fibrin lysis mechanism, which is called a fibrinolytic agent. In general, the fibrinolytic agent usually breaks the fibrin clot, causing lysis of the clot and hence vascular recanalization. Definitely, it has some complications that may increase risk of bleeding, but it has certain indication as myocardial infarction or stroke, etc., etc., etc. And here, some example of the used anti-fibrinolytic or thrombolytic therapies.